All right, so hi again. We're going to talk here about the outpatient management of diabetes mellitus. So we have diagnosed a patient with diabetes mellitus. Now we want to know, how do we treat them on the outpatient level? How do we make sure that we minimize their probability of complications and maximize their quality of life? Now, in the diabetes mellitus lecture, I talked about the drugs used and when you use them for managing their glycemic levels. So I'm not going to talk too much about the anti-hyperglycemics and when you use them, namely metformin, sulfonylureas, thiazolidinediones, GLP-1 agonists, DPP-4 inhibitors. We talk about that at length in the diabetes mellitus lecture. So you should probably watch that before this lecture, but it doesn't really matter. Okay, so with every new diagnosis of type 2 diabetes mellitus, we need to first determine how the patient's going to be treated, and it's done based on their A1C levels and whether or not they have complications. So if the patient has an entry A1C of less than 7.5, so we've made the diagnosis of diabetes mellitus, now we take their A1C level, and their A1C level is less than 7.5, we treat them with monotherapy, metformin. Now these are the new American Academy of Clinical Endocrinologists recommendations. We go right to drug therapy in addition to diet and exercise. So less than 7.5% monotherapy, and it's metformin unless indicated otherwise. When do we not use metformin? We don't use metformin when the patient has renal disease, liver disease, or lung disease, and that's because the number one side effect of metformin, or the number one dangerous side effect of metformin, is acidosis. Okay, if the patient's A1C is between 7.5 and 9, then we're going to have them on dual therapy. So generally metformin plus another drug, be it a sulfonylurea, thiazolidinedione, a GLP-1 agonist, a DPP-4 inhibitor. We have them on 2 different drugs. And if their A1C is greater than or equal to 9 and they don't have symptoms of diabetes, then we'll put them on triple therapy, so metformin plus 2 other drugs. If they do have symptoms of diabetic complications, so let's say they got peripheral neuropathy or they got gastroparesis, then we're going to have them on some kind of insulin regimen. And that can be let's say a once daily insulin regimen plus a monotherapy with an oral anti-hyperglycemic, or just plain old insulin alone. Now, all newly diagnosed diabetics should be screened for complications at their first checkup after they've been diagnosed. And what are the complications? We classify them as macrovascular, microvascular, and neuropathic. So the macrovascular complications include stroke, myocardial infarction, angina, peripheral vascular disease. And this is because with diabetes, you have an increased risk of lipid levels that are dangerous. So we have to we're going to be screening patients for LDL cholesterol levels, but with diabetes, there's an increased risk for complications of hyperlipidemia. The microvascular complications are diabetic retinopathy, nephropathy and albuminuria, erectile dysfunction, osteomyelitis, and infection. And the neuropathic complications are autonomic neuropathy, particularly gastroparesis, and that's just simply because the high glucose levels will they damage the nerves. And then peripheral neuropathy. Peripheral neuropathy occurs in about 30 to 40% of diabetic patients. So this is one of the more common complications. So the initial outpatient management of diabetes mellitus. So all newly diagnosed diabetics should be screened for these complications. So we want to screen them for hypertension. Hypertension is not necessarily a complication of diabetes, but hypertension with diabetes can be severely problematic. So we want to screen them for hypertension if they haven't been already. And hypertension is screened the same way we screen everybody else for hypertension. And that is, we take their blood pressure. If it's more than 140/80, we will check it again on a different day. And if that measurement is repeated, then that's a diagnosis of hypertension. For therapy, we will use an ACE inhibitor or an angiotensin receptor blocker. We prefer to use the ACE inhibitor or angiotensin receptor blocker because they're renal protective, and we may need to use them in nephropathy, so may as well kill two birds with one stone. If the patient is not adequately controlled on the angiotensin receptor blocker or ACE inhibitor alone, then we can go ahead and add hydrochlorothiazide, or we can add a beta blocker or a calcium channel blocker. It's really up to the physician. Nephropathy should be screened for. That's as easy as doing a urinalysis, and we're checking for proteinuria. If there is present proteinuria, then it means that there is some level of diabetic nephropathy, and any proteinuria should be treated with an ACE inhibitor or an angiotensin receptor blocker. And so that's why we prefer to use the ACE inhibitor or angiotensin receptor blocker for patients who have hypertension. We should also get a lipid panel if we have not already. So the goal is an LDL of less than 100. And an elevated LDL should always be treated. So we prefer the use of a statin. A statin is an HMG-CoA reductase inhibitor. It decreases your endogenous production of cholesterol, and it increases survivability in hyperlipidemia. It is one of the only drugs that decreases mortality in hyperlipidemia. So a statin would be preferred in a diabetic patient whose LDL is above 100. Now, you can use it in patients above 100. It's preferable, but it's required in patients who are above 130. Okay, so then a retinopathy screening, and that's done by an ophthalmologist. What we're looking for here is proliferative retinopathy, which can cause blindness, and that's treated with surgery. We also want to have infection prophylaxis. Patients with diabetes mellitus are at a semi-immune compromised state, so we want to make sure that they're getting their immunizations, and so that would include the flu vaccine every year and the 23-valent pneumococcal vaccine. Obesity should be managed as well, and that's done by diet and exercise, lifestyle modifications. If the patient is morbidly obese, you can refer them for bariatric surgery. Some patients are going to qualify, other patients aren't. Generally, they need to be about 100 pounds overweight, or over their highest recommended weight, or have a BMI of greater than 35. But that's really going to depend on whether the surgeon wants to do it. And then smoking cessation, of course, is always recommended. Okay, so hypertension, as I mentioned, the screening is done as normal. And for treatment, an ACE inhibitor or an angiotensin receptor blocker is preferable. Now, the goal is going to be to get the patient under 130 over 80, but you can get by if the patient is under 140 over 90. But anytime the patient is over 140 over 90, that's not adequate hypertension control, and you're going to need to add another drug, be it a thiazide diuretic, a beta blocker, a calcium channel blocker, or so forth. If control is not satisfactory, as I mentioned, adjunctive therapy should be used, but a thiazide diuretic has been shown in some of the literature to be the best first drug to go to for adjunctive therapy. But the best first drug for treating hypertension is an ACE inhibitor or an angiotensin receptor blocker. And so I guess what I'm saying is the best second drug to go to add on to the ACE inhibitor or angiotensin receptor blocker is a thiazide diuretic. Nephropathy, the microvasculature of the kidney can be damaged in diabetes, so we always want to screen for proteinuria. That's always part of the initial workup after a patient's been diagnosed with type 2 diabetes. If proteinuria is present, then we want to put them on an ACE inhibitor or angiotensin receptor blocker. ACE inhibitors slow progression to end-stage renal disease, and so one of the biggest causes of morbidity in patients with long-standing diabetes, particularly if it's not controlled, is ultimate renal failure. Lipids, a lipid panel should be taken after diagnosis. The LDL goal is less than 100. I like to start any patient with an LDL above 100 on a statin, but if their LDL is above 130, you must. So over 100, it's optional but preferable. Over 130, you must start them on a statin. And that could be atorvastatin, lovastatin, pravastatin, simvastatin, and so forth. They're all the same. Exercise will increase low blood glucose, or will let me say that again. Exercise will lower the blood glucose. So I probably didn't write that the best way. Exercise is going to lower your blood glucose. Why is it going to lower your blood glucose? Even if you don't create insulin, say you're a type 1 diabetic, or you're insulin resistant, let's say you're a type 2 diabetic, exercise is going to lower your blood glucose because the muscles take in the glucose, and the muscles do not need insulin to take glucose in. So exercise will lower your blood glucose. Exercise also happens to raise HDL. So exercise is very much encouraged in patients who have hyperlipidemia and in patients who are diabetic overall. Retinopathy. So the microvasculature of the retina can be damaged in diabetes. We want to screen for retinopathy at diagnosis and every year thereafter. For patients with type 1 diabetes, once we diagnose them with type 1, usually we can screen them for retinopathy 5 years after the initial diagnosis and then every year thereafter. This screening is performed by an ophthalmologist, so I don't have any pictures up here. You should be aware of the symptoms because a patient who's diabetic may come to you first with symptoms of diabetic retinopathy. Those symptoms are a loss of visual acuity, floaters, and blurred vision. Anytime a patient comes with subacute visual deficits and they have diabetes, diabetic retinopathy should always be first on your mind, particularly if they have an elevated A1C level, which would show poorly controlled diabetes. The most problematic complication of retinopathy is proliferative retinopathy. And so this would be the worst retinopathy for you to get. There's also non-proliferative retinopathy, but proliferative retinopathy is treated surgically. If the patient has non-proliferative retinopathy, that's just treated with a tighter controlled glucose levels. It's going to take an ophthalmologist to diagnose this because they're the ones who have the equipment and the skills to do this diagnosis. But as far as how you treat proliferative retinopathy, that's done by the ophthalmologist with surgery. Non-proliferative retinopathy is going to be treated by just tighter control of the glucose level. So you may need to tighten or increase their insulin regimen. Infection prophylaxis. So as I mentioned, diabetes leaves patients in a semi-immunocompromised state. It's not like they've got AIDS or anything, but they are at risk for infection. So we do want to give them an annual influenza vaccine, and then a one-time pneumococcal vaccine is recommended. If the patient has had a pneumococcal vaccine and they're under the age of 65, we don't need to give it to them. If they're over the age of 65 and their last pneumococcal vaccine was 5 or more years ago, then we're going to give them a one-time revaccination. Obesity is causally linked with type 2 diabetes. There's a very high correlation. Weight loss is associated with an improvement in insulin sensitivity, and so therefore weight loss is always recommended in type 2 diabetes. Appropriate diet and exercise is how we do this, generally with a low carbohydrate diet, low calorie diet, as well as appropriate exercise. Now in some cases, particularly when you have younger patients, and we do see more and more of them with type 2 diabetes who are profoundly obese, more than 100 pounds over the upper limit of ideal weight, or with a BMI of more than 35 to 40, then we can refer them over to bariatric surgery. It's not going to be us making this decision, it's going to be a bariatric surgeon, and they may perform this surgery. We don't know yet, however, if bariatric surgery increases the outcomes for diabetic patients, because with bariatric surgery there is a risk, a quite significant risk of complications. And then finally, smoking cessation. So smoking cessation reduces the risk of macrovascular and microvascular complications. Duh, this has got obvious health benefits we always want in any patient. We want to recommend smoking cessation, but particularly in our diabetics. Some of the other complications, so erectile dysfunction, this is a microvascular complication. We can treat this with some of the phosphodiesterase 5 inhibitors like sildenafil, tadalafil. You want to ensure that the patient is healthy enough for sex, so you want to look at their NYHA congestive heart failure level. You want to Make sure that the patient is not going through unstable angina. Basically, you just want to ensure that the patient's overall health is sufficient enough for physical activity, because some sex can be, rather high level physical activity. So don't prescribe any of the phosphodiesterase 5 inhibitors like Viagra or Cialis if the patient is on nitrate drugs, and sometimes they will be. Generally, patients who are on nitrate drugs aren't healthy enough for sex. So that's kind of saying the same thing twice. But if the patient's on nitrate drugs, they should not be taking sildenafil or tadalafil because it can lead to a precipitous decrease in blood pressure. Gastroparesis is a neuropathic complication of diabetes. The symptoms are going to be dyspepsia, nausea, vomiting, and diarrhea. Basically what happens here is that the stomach slows down in releasing the digested food into the small intestine. And so this can be problematic. Particularly, this is in patients with uncontrolled diabetes. I saw a patient who was only 18 years old who had diabetic gastroparesis. It already damaged the stomach that much. So very important to control your diabetes. And the best test for diagnosis is a barium swallow, and you'll take an x-ray at I believe shortly after the swallow, and then you'll take it again 12 hours later. After that 12 hours, you shouldn't see any barium left over in the stomach. If there is barium still in the stomach, then you know that there's a delayed gastric emptying time. The treatment is going to be metoclopramide or erythromycin. Those are both, they both stimulate the stomach to release its contents into the small intestine. And then peripheral neuropathy. This is one of the most common complications, so this is last but definitely not least. It is a microvascular complication. Patients will complain of pins and needles, paresthesias, pain, feeling like they're walking on glass, and it's particularly in the feet and legs, but it can be in the hands as well. This is treated with gabapentin or pregabalin. These are the two best drugs. Gabapentin is marketed as, actually I can't remember, is pregabalin? I think pregabalin is marketed as Lyrica. Either way, you don't need to know trade names. Gabapentin or pregabalin are probably the best drugs for peripheral neuropathy, but you can use those, or you can use the anti-epileptic drugs, so like Tegretol or phenytoin. All right, so let's sum this up. So with all of these complications that can come up, we want to be rechecking them at least annually. So for nephropathy, hyperlipidemia, retinopathy, foot health, we want to be checking these patients, screening these patients with a urinalysis, with a lipid panel, with an ophthalmologist exam, with a podiatrist exam, annually, every year, no matter what. For hypertension, all they need to do is see their general practitioner, so we check them every 6 months for their blood pressure. So for hypertension, it's diagnosed when they have a reading over 140/90 on 2 separate visits, and it's treated initially with an ACE inhibitor or an angiotensin receptor blocker, and you can add hydrochlorothiazide if you don't have adequate control. You could also add a beta blocker or a calcium channel blocker, and like I said, hypertension is checked every 6 months. Nephropathy is screened for by urinalysis. If they have positive proteinuria, you're going to treat them because that shows that there is kidney involvement, and you're going to treat them with an ACE inhibitor or angiotensin receptor blocker. If they're already on one for hypertension, then you don't need to add any other drug. Hyperlipidemia is screened for with a lipid panel. If their LDL is greater than 100, you may treat them. If it's greater than 130, you must treat them. I like to treat them if they're over 100 because what I've found is most of those patients just go on eventually to spike their LDL levels. So I would say you should. It's safe to treat patients who are over 100, but it's mandatory to treat patients who are over 130, and that's done with a statin. And statins increase survivability. They reduce mortality in patients with hyperlipidemia. And the recheck for that will be annually. So if their LDL is less than 100, then you can check them again in a year. Of course, if they do have hyperlipidemia and you put them on a statin, you're going to want to check them up in maybe 3 months. Retinopathy, this is done as a screening test annually with an ophthalmologist. They're treated with surgery if they have proliferative retinopathy. If they have non-proliferative retinopathy, then it's going to fall onto you to make sure that they're getting their diabetes under better control. And that may be changing them from monotherapy to dual therapy, or to triple therapy, or to start them on an insulin regimen. For peripheral neuropathy, you're going to treat that when symptoms are present. So there's really no test we can use for peripheral neuropathy, except for, I suppose, if it's autonomic neuropathy. That's not peripheral neuropathy. But for peripheral neuropathy, you're going to treat them when symptoms are present. So the best drugs to use are gabapentin or pregabalin. And you can also use the anti-epileptic drugs like Tegretol or phenytoin. Infection, it's worth to remember that patients who have diabetes are at risk for infection, and so all patients who are diabetic should be getting their flu vaccine every year. And if the patient is over 65 and it's been more than 5 years since they've gotten their pneumococcal vaccine, then you should give them one-time revaccination. If they're under 65 and they've already been vaccinated, you don't need to give them a revaccination, but if they haven't been vaccinated, then you should. So that's the 23-valent pneumococcal vaccine. For obesity, you're going to treat this when it's present. Generally, diet and exercise are what we use. If the patient is severely obese, meaning 100 pounds over the upper limit of their normal or acceptable weight, or if they have a BMI of more than 35 to 40, then you should refer them for bariatric surgery. That's, of course, going to be beneficial in the younger patients, not so much in the 75, 80 plus crowd. And that's just going to be done at the decision of the surgeon. And then, of course, smoking cessation, always recommended. Stop smoking. It reduces your risk of vascular problems, and it reduces your risk of hypertension. And that is it.